This is SG2 Perspectives, a conversation with industry experts and SG2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
We've had phone conversations, Zoom conversations with our strategy members over the last couple of weeks, and that question comes up: where do we fit? What should we be working on?
Hello, and welcome to a special edition of SG2 Perspectives. I am your host, Kelly Richard. Today, we will be covering the all-consuming COVID-19. There's not a corner of the earth free from thinking about this pandemic, from the public health impact to the economic consequences of the spread. However, we at SG2 are going to try to focus on what we do best and discuss COVID-19 from the strategic lens of a health system. Today, we have a panel of experts: Bill Woodson, our foremost thought leader in enterprise strategy; Marty Lucenti, SG2's resident emergency medicine physician and operational engineer, as well as military strategist. He's got quite the resume. And Chris Pagano, our lead expert in virtual health. Let's get on with it. For the vast majority of our members, this is a time to focus on day-to-day clinical operations and the immediate needs of very sick patients. Marty, what are your thoughts from both the clinical perspective and the operational perspective on what health systems need to be thinking about now?
Thanks, Kelly. Yeah, so as you look at this pandemic as it moves across the world and into the United States, health systems are faced with a number of different challenges that are relatively unique for them. What you see is, on a clinical perspective, there's the uniqueness of attacking this particular COVID-19 virus and understanding the epidemiologic properties of that pathogen. And so there's a lot of work understanding those dynamics. I think the other thing that's really changing the dynamics around the country is, all of a sudden, people are really having to understand the mathematical modeling of pandemic movement, meaning that all of a sudden, in order to really know where you should be and what you should be doing operationally, you've got to start to have a strategy around what is the timing and the order of magnitude that the pandemic is going to hit you. Are you going to be like Wuhan? Are you going to be like Lombardy, Italy? Or is it going to be subtly different? And so folks are going to have to, number one, operations starts with a clear understanding of what you believe, probabilistically, what you believe are the potential scenarios playing out in your local market. Once you make some of those things, then you have to move over into a series of really important strategic and operational decisions. And that starts with really understanding the dynamics of this pathogen, understanding how to minimize transmission. So understanding what your local strategy is for testing, where that testing is, whether that's in your emergency rooms or if that's a separate space, how you're going to respond to the operations that for all your patients other than those potentially exposed to COVID-19. So that balance between continuing day-to-day operations while you ramp up or ramp down in response to COVID-19. Then you've got to work on the transmissions and what your local policies are around healthcare workers, what the PPE standards are for your organization, and start to understand solving some of those logistics. Some folks are challenged with supply shortages of some crucial items. So all of those things folks are struggling with. As you can see, some places are already deep in the midst of the battle. In other places are quietly wondering when it's going to get to them. And so all across the United States, folks are struggling with where they are in this pandemic spread curve and trying to understand what their predictions are for the degree to which it's going to hit their local market, while working on the basic approaches to mitigating transmission, determining your testing strategy, figuring out what your quarantine or social distancing policies are. All of these things are coming together and affecting on a day-to-day basis your core clinical operations.
Sure. It's really sounds like it's strategy and operational integration in real time. At SG2, we focus a lot on strategy, both shorter term and longer term. And really at this point, I want to go to Bill here. What role, if any, does strategy play right now?
Thanks, Kelly. We've had phone conversations, Zoom conversations with our strategy members over the last couple of weeks. And that question comes up, where do we fit? What should we be working on? And depending on the system, they may already have their marching orders, or they're being very careful not to get in the way of the tough clinical operational work that's going on right now. But in general, what we're recommending is that if you're in the strategy, planning, business development area, you need to be able to work under 3 timeframes simultaneously. So there is the here and now, and this is where that team, the strategy and planning team, can go to work on capacity planning, bed need across a system, across a region, perhaps in cooperation with other providers in your market. This gets into med-surg, ICU, vents, and even those campuses that aren't treating COVID-19 patients, their capabilities, their capacity. It's a here and now dynamic planning process where our members can play a critical role. That's the here and now. The next level is sort of the medium term. And we've already received this question. Okay, SG2, we expect to get through this in the next 60, 90 days. Pick what we know or don't know. How do we bring our health system back to business capacity? How do we restart our elective procedures? How do we chase growth in the market that we know will be pent up? There will be demand for procedures, and we have to decide how to kind of reignite that demand and channel it back into our system. And for all we know, competitors will be doing the same thing. That's the medium term. And then longer term, you still have your basic strategic imperatives. Your plan is still in place. However, it may have been upset by this crisis, but that's where you return to your work and keep an eye on your work on what you're building across the system of care, how you think about service distribution, which services go where across the system. This crisis will elevate that concern. Consumerism, network integrity, how do you keep patients in the system, destination strategy, and in particular, digital strategy that I know Chris will talk about in a moment.
Maybe just add a couple things to Bill's comments there. I mean, I think, first, don't lose this opportunity as a pressure testing of your strategy. Many organizations in healthcare haven't really gotten to the concept of high reliable system design and strategy towards achieving a high reliable system design. And I think what we're seeing is some of the challenges that we're seeing over on the operational and clinical side are based on some non-stochastic modeling, some sort of deterministic modeling. And so when stressors like this come, we're uniquely not qualified to respond to them. So don't take, I always tell strategy folks on this front, don't miss the opportunity to say, were we well positioned for this? Were we resilient to these sort of stressors? I think those are important questions as you develop your next generation strategy, is to be a little bit more in tune with some of these things. And then understanding too, from a strategic perspective, this ramping up and ramping down. What you're actually seeing is, because people are running at such high operational, at such high census points, they're uniquely challenged with the ability to respond to these struggles, which is going to create a secondary financial situation. Is they're going to have to decrease activity in order to create capacity, as opposed to strictly working on ramping up from baseline operations. And so some of those things are changing the calculus of the strategic plan going forward. At least it's worth giving some thought to. Anything else, Bill, you'd add to that?
I love it. And, we talk about scenario planning all the time. And this is a scenario that I think very few of our members have worked through in the past, save some in the Southeast that have dealt with natural disaster scenarios. Marty, I love the concept is use this opportunity to test the assumptions in your strategy, and that question, what must be true for our strategy to succeed moving forward?
Yeah, because I always, what I would say is have somebody who's done a lot of disaster work. What I always question is, were you prepared when your response to a disaster is to ramp down your operations? Okay, and that's what you're seeing a lot of folks doing, is ramping down their operations. And that shows that there was a failure to be ready for that surge up. And so they're having to do the opposite. That especially with a pandemic like this, where timing is incredibly difficult to predict, the financial consequences of having to ramp down in order to be able to deal with a surge can be really financially destructive to an organization. So this is one of those scenarios where, you'd love to get to being an organization that the response to increased emergencies and increased emergency demand, is an ability to ramp up and not necessarily require a ramping down on other fronts.
Yeah. And Marty, to expound upon that a little bit more, since you are an emergency medicine physician, how should our members be thinking strategically about their emergency services now, as that's, really sort of the front door for a lot of the response here, both their response now as well as after the crisis is over?
It comes back to that basic question, which is, are you running your operation at near full capacity on a routine baseline? If I want an aircraft engine to last a long time, I don't run it at 100%, I run it at 60%. So it has some resiliences and it has some ability to surge up. Look at your emergency systems. Most emergency rooms around this country are really actually meeting the normal day-to-day definition of a disaster each and every day. And so in that context, what you're faced with is a mandatory ramping down in an attempt to create capacity for a different type of day-to-day disaster. And so that's a question you've got to start to ask. Nothing that really, if you look at high reliable systems that have to always be resiliently there for you, you do not want to run at 100% capacity all the time. We tend to have created a model across the US where that's actually how we're running our emergency services.
And really kind of bringing that out to the full system of care, what are the strategies that systems can employ to better leverage that system of care as patient needs are evolving right now?
Well, I think this has been a common message from SG2, which is the ability. So we've been talking as a long-term strategic plan to move people out of the acute care setting and being more flexible and start to drive more and more of your encounters to an ambulatory setting. Folks that have been working on that endeavor can actually use some of those initiatives. The successes on those fronts are going to be what drive the ability to offload your acute care while keeping operations going. And I see lots of different models going around the country, but an organization that's been, from a long-term planning perspective, trying to move towards an ambulatory care encounters and moving things that direction, they've got a foundation to try to shift some of the stuff that's ultimately going to need to go to the emergency room. They're going to be able to shift some other stuff even faster. They're going to have some muscle memory on that front. Whereas organizations that haven't been working on that have really been focused on just driving everything right at the acute care facility is really ill prepared to start to say, hey, what encounters right now should we be doing in the primary care? Should we be doing in an ambulatory setting? How are we rerouting some of these things? Not shutting them off, but rerouting them. I'm seeing examples across the U.S. where people are even just shutting off those other things and almost creating more of a funnel right at the epicenter, right at those acute care facilities.
And I think that's a great segue into virtual health. In the past, it's really been more of a nice to have rather than, the necessity that it's become over the last couple of weeks. Chris, I'd like to go to you here. How are clients utilizing these services to better serve patients?
Yeah, absolutely. So needless to say, keeping patients out of healthcare facilities is pretty much what every organization, of course, is focused on currently. And so therefore, the focus is really on the home. For COVID-19 patients, what this really means is triaging patients in their homes as much as possible, identifying which patients are perhaps at risk that they've been exposed to COVID-19 and understanding which of those need to come to the hospital immediately for testing. And one of the key ways we're seeing so many organizations do this is through utilizing, of course, virtual health. And some of that is synchronous video in nature, really reallocating their direct-to-consumer resources towards being able to provide these video triaging capabilities, as well as asynchronously. Seen a lot of organizations adopting and deploying smart surveys, modifying those to be in line with the CDC guidelines, and really thinking through how are we utilizing our providers as effectively and as efficiently as possible. In addition to that, we've already, of course, seen a lot of organizations leveraging remote patient monitoring capabilities to monitor patients in their home instead of perhaps admitting them if it isn't necessary, or post-discharge, of course, as well. I think the other way I'm seeing it in a lot of organizations is really thinking through how can they extend the reach of a number of their infectious disease specialists in particular. Of course, we have a shortage of those individuals. And so when patients are not just presenting at the ED, but they're presenting across the entire system of care, I think that the other part of this, of course, is for non-COVID-19 patients. But those who still do need care, a lot of these are chronic care patient populations. They are particularly at risk in this situation. So seeing a lot of organizations who are actually very quickly scaling up those ambulatory capabilities across all of their different ambulatory clinics, utilizing virtual health as much as possible to do some of those more non-emergent visits with those patients, still allow them to get the care they need, but not necessarily come into a facility where, again, they might run the risk of exposure.
Chris, the follow-up question for you, this is Bill. We're wondering how well these platforms have scaled for the virtual health needs that are being demanded from them today. No need to mention specific platforms, but were we ready for the volumes that were going to come our way?
No. In some cases, that's meant very, very long wait times. It's meant reductions in terms of the quality, especially with video visits, the quality of those interactions, because the bandwidth simply wasn't there to be able to handle it. We've seen some cases where it's actually broken effectively. The other way it's been challenging is most organizations weren't staffed around virtual health to handle this level of volume. Of course, normally you would be staffing up in parallel to the increase in volumes. We've seen organizations, I've spoken with a number of them who are talking about where they went from having maybe 10 APPs who were staffing their direct-to-consumer virtual health offering to a week later having 75. So there's rapid ramp up, but the reality is that it is being done in such a rapid way that there are certainly a number of challenges involved with doing it that way, because we just simply weren't prepared for this level of volume this quickly.
Yeah. And Marty, just to go to you a little bit on the clinician's perspective of very quickly and widely using telehealth, what are the challenges?
Well, I think this is going to accelerate people's realization that many encounters that we were somewhat hesitant to move to a telehealth modality really actually can be safely and effectively done in that modality. And in this context, right, is that transition of modality actually helps to mitigate some of the spread of the illness. So as much as possible, moving things to telehealth encounters where appropriate make very, very good sense. Folks that have done the hard work up front to get ready on that front are really, really, really benefiting from the fruits of their labor.
Great. And Chris, I know you follow this stuff really closely. In the past, a huge barrier to telehealth has been some of the regulations around it, the payment.
Yeah.
What have you seen in terms of the most impactful changes from a policy front that we're seeing come out in order to remove those barriers quickly?
Yeah, that has been obviously very interesting to watch as well. So in an emergency capacity, we've certainly seen CMS in particular take a lot of action. For those listening, they may be familiar with HB 6074. That was the Coronavirus Preparedness and Response Supplemental Appropriations Act of 2020. So that act, actually part of that contained quite a bit of language that afforded certain powers to the Secretary of HHS to essentially be able to waive a number of the limitations that have been extraordinarily restrictive historically to virtual health adoption. So namely, what they removed were the geographic and site restrictions, allowing the home to actually serve in particular as that originating site. That had been a very, very significant challenge historically. Even something as basic as HIPAA requirements has been removed in relation to virtual health in terms of you don't necessarily need to use a platform that meets those HIPAA requirements. You can use FaceTime. You can use Skype. Again, this is in an emergency capacity. And so what's going to be really interesting to watch moving forward is how much of these restrictions do they try to put back on when this crisis has passed? I think it's going to be really challenging for them to be able to do that, but it's going to definitely be interesting to watch as you see so many organizations making rapid investments in the virtual health space and really realizing the benefits that virtual health can deliver. I think that it's going to be, again, very, very difficult for them to try to put those handcuffs back on and make it more difficult to use these capabilities, especially when these investments have already been made and utilization is ramped up to the level it has.
And just to kind of shift the conversation a little bit more toward the workforce component, a health system's greatest asset all the time, but particularly in a situation like this, are their workers. What strategies do health systems have at their disposal to support their frontline staff? Marty, let's go to you first.
When you look at the staffing side, it actually, I always like to start with the realization that whatever capacity you want to have, i.e. the ability to provide patient care, what's really important to understand is that you've got to align your resources. And so if you want your capacity to be at a certain level, you've got to make sure you've got alignment of the crucial resources it takes to take care of patients. And I always start with it takes for three basic things to take care of a patient. And I see a lot of planning around capacity, but I see it mostly on the bed planning side. Is it really takes three resources. It takes a doc, it takes a nurse, and it takes a bed. And if you have enough docs to see 10 patients and you've got enough nurses to see 5 and enough beds to see 7.5, you're going to only be able to see 5. So your capacity is only as good as your most constraining variable. So it's really, really important as folks start doing disaster planning that they really look at the alignment of docs, nurses, beds in terms of capacity. Now, there's lots of different things happening as folks start to expand, figure out models for expanding their capacity. On the staffing side, you're seeing a lot of folks looking at intensivist extension models. You're seeing folks really looking at, once again, things that SG2 does talk a lot about, which is getting people practicing at the top of their license. And so it's about making sure that you've got a model that allows people to practice relatively close to their top of their license. And that's a very, very important endeavor when you start talking about disaster planning. This is a big part of actually what the military does in response to dealing with those surges and disasters over in combat areas. Is there's a real emphasis on making sure folks are practicing at the top and sometimes occasionally above their scope of practice. So lots of work on those fronts, and folks are really working on the work rest cycles you're seeing. I think a big part of this whole thing is know where you are in your pandemic curve locally. Because what you're seeing is as you go into quarantine, as you go into social isolation and social distancing, you'll typically see a decrease in your demand in the emergency rooms, in the emergency care settings. Use those opportunities to make sure you're getting your staff the rest that they need, and then have a plan for what your surge upward model is. And so capitalize on both the relative lulls that come before a big disaster and be ready for how you're going to staff up going forward. Understanding scope of practice is a big part of that.
Another follow-up question there. If we're seeing the reduction or complete, stop essentially of elective surgeries or elective procedures, is there a way to repurpose staff that would be doing those types of things to help increase capacity for the emergency treatment that's needed right now for COVID-19?
So what you're seeing is a lot of places, in order to have, the constraining variable is going to be for us in this case is typically ICU beds. And so you're seeing a lot of strategies to say how do we create ICU capacity? And one of the first things people are doing is they're decreasing ICU demand by mitigating elective surgeries. And so you're seeing folks are trying to come into the heart of the pandemic as it hits their local market, as it hits their facility. They're trying to come into that with an ICU census more like 50% than the sort of standard 75, 80 5% that we typically run those ICUs. Folks are taking the time to take some of the folks that are doing some of these other things and retraining and repurposing them so that they can essentially be physician extenders or clinical extenders to folks in their non-primary area. So folks, could be working in another setting, coming over and being an extender to folks that are, specialized in one care setting or another.
Great. And even from the virtual health perspective, Chris, are you seeing health systems support their frontline staff or do any sort of repurposing or changing the way that they deliver care for the purpose of their workers through virtual health settings or modalities?
Yeah, it's a great question. So we are. I mentioned earlier that, I was speaking with an organization actually last week or so, and they were mentioning, well, we went from about 10 APP staffing our virtual health capability to 75 in a week. Well, part of that involved that they had to re-credential them, right? They had, for some of those individuals, they had to actually change their scope of care. And so there's a huge administrative aspect to doing all of this. And for them, one thing we talked about was how do you align your administrative processes to ensure that those changes can be done in a streamlined fashion so those clinicians can be deployed as efficiently and as quickly as possible, right? I'll also offer, again, one of the big constraints is just physician clinician capacity. And so, yes, part of that is how do you use those individuals as efficiently as possible. But the other part is how do you try to find ways to leverage technology to alleviate some of their tasks. And so we've definitely seen, again, some organizations who have adopted smart surveys and different types of automated triaging capabilities. And by leveraging those automated triaging capabilities, that is time that can be potentially reallocated towards seeing a patient or two before the response to that survey needs to be actually evaluated. And then there may or may not be some additional discussion with the patient. So again, thinking through a comprehensive strategic approach to how you're utilizing technology to support clinicians and physicians on the front lines to not only keep them safe, but allow them to work as efficiently and as effectively as possible. I think that's the way that a lot of organizations are thinking about this.
Yeah, and that's very much in line with Marty's point about allowing providers to practice at the top of their license.
Yep.
So in addition to some of these shorter term challenges that we're seeing, obviously we're all in sort of this emergency mode, but I'd like to turn it over to Bill a little bit to talk about the longer term effects of the pandemic on health systems, both from a financial perspective as well as sort of what you had mentioned before, Bill, about ramping up those elective procedures and services again after the big wave has passed.
Yeah, there's so many topics that swirl around this right now. We're going to learn as we go, as the crisis abates. I'd like to tie on to the workforce discussion. We've seldom talked about workforce as a strategic asset, but that's exactly what your workforce is. And we will be encouraging SG2 members to take the time to celebrate the amazing efforts that their colleagues and teammates have put into this crisis. And I suspect people in the community will acknowledge that and recognize that as well. Please take the time to do that all over the health systems that you work in. And then think about moving forward how you will use your workforce to differentiate yourself in the marketplace. The last part of our discussion is that we now have, or we've learned potentially the ability to reskill a workforce or to give a workforce new skills. That then releases some of the restrictions we had on deploying strategies around service distribution, how we run our access channels, what procedures we potentially provide in an ambulatory setting versus on the hospital campus. These things are all linked. As we move into next year and beyond, I think the aftermath of this crisis will help us to think more regionally as strategists. It will accelerate kind of the master facility planning to deal with capacity issues that was already underway, particularly at the academic medical centers across the country. There will certainly be policy repercussions and implications that come out of this crisis that connect to expansion of Medicaid in certain states, how we deal with value-based care acceleration, how we deal with just the cost of care like this, surprise billing. Those issues will probably see some heightened attention at the state level and at the federal level. Based on what Marty said in the beginning here, this is a great time then to revisit, or will be a time to revisit, your consumerism and access strategies across the system. And what channels do people use to enter? Are they new channels? How do you accelerate them? How do you tap into that demand that's in the marketplace to make sure you're keeping your fair share of the business that's out there? For those second place health systems in markets around the country, this is your moment, right? This is your moment to seize some of the business that you might not have gotten this year or next. And even more broadly, let me just expand our thinking here. We spent the last 2 years with our members holding sessions on how health systems play a role with social determinants of health. And there's a continuum of what roles systems can play. And at a minimum, you're on the receiving end of the clinical manifestations of those social issues. I would say coming out of this crisis, this will cause you to expand your thinking, to reconsider partnerships or to evaluate partnerships that will help you over the long term and bring a certain degree of regional planning across the continuum that we haven't had before. I'm optimistic that this is going to liberate some of the strategic gridlock that we had inside a lot of systems that we work with, some hesitation to make some tough decisions. I'm hopeful now that we're going to start making those calls, and that allows us to then go back to those scenarios and scenario planning to test our hypotheses and to deal with the planning cycle in a whole new time frame and with a whole new level of urgency.
And when you say accelerated decisions, Bill, are you thinking on the mergers and acquisitions side? Do you see more physicians being bought up by health systems or more health systems joining together, or is this more of a partnership play?
I put it in two categories. So I think it is a partnership approach to how you fill in the gaps across the system of care, including post-acute and all things outside the hospital. But within the health system, I think the pivotal decisions will get into what are the multiple hubs that you have, for example, for stroke services or for complex heart procedures. Will you be able to designate one or two campuses across your system purely for orthopedic and spine care? Those historically have been really challenging political processes. I'm hoping that going through COVID-19 frees us up a little bit to say, you know what, we can do that. And if we have to redeploy the workforce, if we have to make some trade-offs, we know that we can do that if we have to.
There's an operational saying, never let a good crisis go to waste. And I think what Bill's emphasizing is moments like this give us the opportunity to accelerate some of the changes that we know we need to make, but we've been moving slowly at.
Absolutely. Well, thank you, Bill, Marty, and Chris, for joining us for our COVID-19 episode of SG2 Perspectives. And thank you to all the frontline providers and staff working tirelessly to care for these patients every day. And to all of our listeners, stay healthy.
This has been another great episode of SG2 Perspectives, where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you. SG2 revolutionized healthcare demand forecasting with the Impact of Change forecast, and today we're the industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks so much for listening, and we'll see you again soon.